Hi, my name is David Rapaport. I'm a board-certified plastic surgeon who's been board-certified plastic surgeon for 30 years now, believe it or not. I want to spend some time now talking at some length about breast implants, specifically from the vantage point of being a plastic surgeon who's performed hundreds and hundreds of breast augmentations over the course of 30 years. So I want to explain a little bit of terminology that you need to understand for the rest of this conversation, and talk about kind of the history in the United States, like what have we been doing? What do I do that I think is actually worth it for you to hear about that other people aren't doing so much in New York, which is true, which is kind of cool. And also kind of cool and interesting is what changes are happening now, because we are at a precipice of change in cosmetic breast augmentation, actually right now at that precipice. So it's all very interesting. So I think sitting down and finally recording this longer talk about breast implants, I think the time has come. So in terms of terminology, the real silly thing, but if I talk about the nipple, I'm referring to the nipple areolar complex. So that's the areolus is the pigment around the nipple. That also has a different texture and color, right? And the nipple is the protruding thing. I will talk about breast volume, and it seems very simple. So breast volume is how much volume, how many cc's are in your breast. I'm not talking about an implant right now. You know, how many cc's, if you put a big hand on it, how much volume is it? Or if you took it off your body and put it in a thing filled with water, how much water is it going to displace? What's the volume of the breast? And so we think of volume in cc's. Separate from the volume is the term skin envelope. And if you're going to learn one thing from this, that's a key word. If you're going to get breast augmentation, it's good to understand skin envelope. So skin envelope is exactly what it says it is. It's the skin container. So that's different from volume, right? Because you could have a certain amount of volume that, let's say, makes for a C cup, but you have a huge skin envelope and this whole saggy breast is just hanging down with a whole lot of skin. So that's a discrepancy, right, between having a big skin envelope and a little bit of volume. If you have a lot of volume in a small skin envelope, you have a tight, perky breast, which most people don't complain about, and it gets different over time. But let's say you get a very large breast implant and you're 22, that discrepancy is going to put tension on your skin and, for example, might very well increase your risk of getting stretch marks for getting a big volume in a smaller skin envelope. Then another term I'm going to mention, which is an important term, is the base diameter of your breast. Just if you're more a little geeky and want to understand how we do sizing, the base diameter is the key thing. It's the key measurement number. You know, how far your nipple is from your sternal notch, which is this notch, is also important. But the key number in any breast augmentation planning, the most important number, is the base diameter, the width of the base of your breast, like the base of the building. Why? Because think of an attractive breast very, very slightly like the map of Japan, meaning the red circles in the middle, the nipple's in the middle. You can't really cheat with having the nipple in the middle of the breast, because if you push the volume to the middle because you want cleavage, now the nipple's here, it's kind of looking this way. And if you do the opposite, now the nipple's looking this way. So it needs to kind of be the cherry on top of the breast mound. If any of this makes sense, I hope it does. You want the nipple to be the center of the chest mound so that the nipple's looking straight ahead. The same thing if you have the breast mound too high. If you put an implant in and it's sitting too high, now the nipple's looking down, and that's not a good look. Similarly, when the implant's a little bit low, the nipple might look a little up, which might be a good look. But the other thing we're going to talk about later on is the dynamics of breast augmentation. And this is maybe one of the harder things to teach people, which is that getting a great job, getting a great breast augmentation isn't at all just about how you look 3 months later when you can really see this is the result. This is what they look like. They're beautiful. Because if they're big, especially if they're big, more than anything else, that dynamic's going to keep going on, right? If you have a 500 cc breast implant here on a person that doesn't have the thickest skin, doesn't have the strongest tissues, and that doesn't wear the best support all the time, what do you think is going to happen? There's going to be wear and tear on the skin. And depending on the implant, that wear and tear might become evident in different ways. And I'm going to try to teach you help you understand about that too. So we've gone over some terminology. We talked about the nipple. We talked about the breast volume. We talked about the base diameter and the skin envelope. Those are all important things. Talking about skin pinch, how much skin you have, especially in the upper pole. We talk about the lower pole, which is sort of the breast tissue that's below your nipple, and then the upper pole is the stuff that's up here. Okay, we're going to come back to all that. I think that's enough terminology for now, although we'll probably touch upon some other things. Now, this educational thing is about simple breast augmentation. So I'm not going into any detail now about if you have a saggy breast, what we call ptosis, if your nipple is below the fold. That was the other term I was going to mention. IMF we use a lot, and that stands for inframammary fold. So, where your breast naturally folds, and then you may have skin hanging below, we call that pseudotosis. So the IMF is something to know about. So anyway, I'm not talking about cases of sagginess where you need a lift, aka mastopexy. I'm talking about a woman who has either a deflated breast or a breast that's just smaller than she wants, but the nipple's in a reasonable position. It's not really saggy, and you want to get your breast filled. And what should you do? So let's break down all the decisions that kind of have to be made one way or another, whether they're made actively or passively, okay? So we're going to start by talking about the incision. What incision options and what's my preferred incision for a basic, meaning a straightforward breast enhancement. I'm not doing lifts, right? Because if you have a big saggy breast, you need a lift. You need all kinds of scars to reduce the size of the skin envelope. But here we're just growing a breast that has a good shape to begin with, okay? So, short story. There are 3 theoretical options. There's in the IMF or near the IMF, the inframammary fold. That is by far the most common incision in the United States, by far, probably 98%. There was, and still is in theory, the periareolar, which usually means the lower border of the areolus. Okay, that's way out of favor the last 20 years in the United States. I'll explain why. And then there's the underarm, which is my fave. Why is it my fave? Because the underarm isn't subject to great scrutiny, number 1. Number 2, you have wrinkly skin in your armpit. Number 3, a scar in that wrinkly skin in the armpit becomes usually invisible. And if it is visible as a fine line, tell me who cares. So I love the underarm approach because it is the most friendly approach in terms of elegance, in terms of not having a scar on your breast. Now here's what's kind of fascinating. The population of humans on this planet that has the reason to be most concerned about their scars are the Asian people. Why? Because they tend to form worse scars in general. So an inframammary fold scar on an Asian woman, now on any woman, if you're small-breasted, so your breast isn't hiding the scar, so you're more anxious about it. But Asian skin, that darker skin, tends to form thicker scars on many, many people. So you don't want that. Now, the Asian market is a well developed, and I don't have to explain to you how successful China is and how successful Taiwan is and how successful South Korea is as economic countries. So they have money, they have disposable income, they have women that love fashion, et cetera, et cetera, et cetera. So breast implants, these are aesthetically Western-oriented places that have similar, they feed into the same kind of demand as our population. So there's a lot of breast augmentation going on in South Korea and in Taiwan and in China and Shanghai, of course. Guess what? Most of it's through the underarm. Why? Because they're prone to have worse scars, and it's a competitive market, and they know what they need to do, and they learned it. What's fascinating about the United States is that, surgeons are creatures of habit, so I get it, but it kind of blows my mind that only me and one other guy in New York have a respectable amount of experience at the underarm approach using a scope. Using a scope means you see what the hell you're doing, okay? There is another fellow in New York who's a tremendous plastic surgeon, but he doesn't use a scope, and I just have a hard time understanding why he's doing this operation blindly, even though he gets good results. I trained in the operation as a blind operation, but now that I see what I'm doing with the scope, there's no turning back. So, yes, I have a vast experience in putting breast implants in through the underarm, which means and I'm doing that here in New York as well as in Tel Aviv, putting them through the underarm so that you have no scar on your breast, which is really awesome. I tell every woman, by the way, just like when you get your gallbladder removed with the laparoscope, if anybody's had that, there's always a chance of a scar on your breast, but it's only happened once in my career. Meaning that if there's bleeding that I can't control or some sort of problem like that, you could wake up with a scar, but only one out of hundreds woke up with a scar. Everybody else we've succeeded, including replacing implants, and we can talk about that a bit later. So I do that a lot. I do it endoscopically. Okay, so what are the questions you're gonna ask? Are there any negatives about doing this? Well, there are some maneuvers you can't make. So not everybody's a candidate. Most people are. Other than that, you need to just know what the hell you're doing. That's the main issue with the technique. You have to be really good at it. You have to understand all about, when you're talking about breast implants, the perfect, beautiful breast has an implant sitting, if it's implanted, the implant sitting just right. Meaning an implant that's too high never ever looks good. It might look good in a bra in your clothing, because there's a nice little bulge up top, but when the bra's off and the chest is bare, it's nothing, it looks like nothing that nature made, meaning nature doesn't make a breast that has fullness above the nipple areolar complex. It just doesn't. It doesn't look natural. It doesn't look good. And if anything, the opposite is true in the last 50 years, that modern man and woman seem to, if anything, like to see more distance between the nipple and the bottom of the breast, meaning more fullness in the bottom and a little bit less in the top seems to be what people like. So that's what we're trying to do. I'm not trying to do a breast augmentation that's kind of okay, that you'll go away because I'm going to tell you it'll get better and it'll never get better, because I've seen too many of that. I'm looking for something, we're trying to do perfect, and we all need to understand that it's a challenge. So we've talked about scars somewhat exhaustively. No, we haven't. I haven't told you why we shy away from the areolus, and I'll give you two huge reasons. And the two huge reasons are as follows. One is capsular contracture. Capsular contracture is hardness, and it's thought to be formed, well, we know that it's formed because the scar tissue around the implant is squeezing the implant, and it makes the implant feel hard, sometimes even as hard as a rock. Even though the implant itself is the same soft implant. It's crazy, but it's true. So we know that many cases of capsular contracture are caused by kind of low-grade infection. There are bacteria growing layers and layers on your implant, but they're not sort of evil enough bacteria that are going to give you an elevated white count, a fever. They're going to make actual pus happen, and you'll need an operation to remove your implant. They're not that bad, but they're bad enough to cause a chronic low-grade inflammatory response. Another word for what these things are is called biofilms. And it's a whole field of study that's about 30 years old that we don't fully understand. But if you have an IV line, if you have any kind of synthetic thing in your body, there's a very good chance that there are biofilms growing on it, and we become more aware. So anyway, those biofilms can cause capsular contracture, so we've learned to keep our incision away from the little nipple, because just like my nose might be clean, and I can prep the skin around it, but inside my nose has bacteria because they have free passage in and out. The nipple's the same kind of thing. It has little ducts. So there are little bacteria inside the ducts. So even though you prep it, when you're doing an operation and touching and things like that, there are little bacteria leaking out that you can't see. So therefore, the no-touch technique in breast augmentation was developed in the last 15, 20 years, which means you're trying not to touch the skin, and you're trying not to touch the implant with anything like that you can help, like your gloves. So the no-touch technique means we're not putting a scar under your areolus, and we are putting like a tegaderm, a sterile layer over your nipple and nipple areolar complex, so that there aren't bacteria that we can't see leaking out during your breast augmentation.